Test 1, 2, 3. Officer Barry Liu, Director of Retiree Healthcare Cassandra Smith, and consultants Steve Murphy and Michael Seslow from Siegel. Trustees, please use your raise your hand option to be placed in the queue. At this time, we ask all meeting participants to mute your mic until you're ready to speak. And now we may proceed with the agenda.
Thank you very much. We don't have any 2449 participants today. Approval of the minutes, item 3A of the September 3rd meeting. I need a motion.
So moved.
Okay.
I will abstain. I was not there.
Okay. Mr. Oakham is absent. 1 second. Ms. Langton. Okay. Mr. Moore.
Yes.
Mr. Kehoe.
Aye.
Okay, and Mr. Robin abstained. Thank you.
Item 4 is public comment. We do not have any requests from anyone from the public to address the committee. Non-consent items are 5A, federal engagement visit with Congress. Mr. Liu, briefly.
Yes, good morning, Chair Robbins and trustees. So this item relates to our annual participation in the CPERS conference, and this is a good opportunity to also stack in meetings with members of Congress. Some of those meetings will be set through in CPERS, and also our own lobbyists may be able to set additional meetings the day after. So I would just ask for your approval of this recommendation.
Thank you very much. So anyone interested in attending that, just let me know.
I'll move it.
Hmm?
I'll move the item.
Okay. Ms. Langton? Yes. Mr. Moore?
Yes.
Mr. Kehoe?
Aye.
And Chair Robbins?
Aye.
Okay, the motion passes unanimously.
Thank you very much. Reports, item 6A, engagement report for September.
Thank you, Chair Robbins. Some items of interest this month. The first one, it's an item about, I guess, a fairly prevalent myth about whether millennials and Gen Z workers tend to job hop a lot. As you've seen during the years coming out of the pandemic, there was a period of time in which it was sort of a buyer's market for workers. They were just changing jobs very frequently for higher salaries. But the National Institute of Retirement Security looked at this phenomenon and found that it this generation doesn't really do that compared to prior generations. So they compare, for example, millennials and Gen Z age 25 to 34 in 2024 versus baby boomers of the same age in 1983, and found that they had a similar tenure in their jobs, about 2.7 years. And then the report also found that economic conditions rather than generational attitudes would drive attrition. So generally, if you have a strong economy, people tend to move jobs more, but they tend to fall during recessions, such as the Great Recession and the 2020 pandemic. And then the other thing is how this relates to the public sector. Definitely longevity is a desirable, condition in government employment, and it found that public sector benefits such as pensions and healthcare really do a good job in promoting retention and longevity. So state and local government employees definitely have a lower attrition rate than, say, private sector employees. And then the other thing has to do with, industrial differences. So in manufacturing jobs, they generally have stronger benefits and also stronger union presence. So you see higher retention rates there compared to, say, retail and professional services. The next item contains some interesting statistics about the business we're in terms of pension benefits. So the first one is about state and local pension benefits. And the Federal Reserve data on this shows that as of the second quarter of 2025, public pension assets were about $6.5 trillion, and that's a 6.9 increase in the previous quarter. And this is the highest increase since the fourth quarter of 2020, during the pandemic years. And then the next item is about really pension funds worldwide. So this organization called the Thinking Ahead Institute looked at the 300 largest pension funds in the world, and collectively they manage over $24 trillion in assets. And this, again, surpasses the record of 23 trillion in 2021. And so these funds have a mix of defined benefit and defined contribution funds, and it found that about a little over half of those funds are public sector pension funds or sovereign wealth funds. And if you look at North America, it accounts for almost half the pension assets at 47%. And then within the US itself, it accounts for about 41% of total assets. And just looking at some of the largest funds in the world, it includes, Norway, Japan, the US's federal retirement plan, and then as well as South Korea and the Netherlands. And then the last item, it's about the effect of unions on workers and communities. This is a report from the Economic Policy Institute, and it found that there's a strong correlation between high levels of unionization and then just a range of economic, personal, and democratic well-being measures. So for example, between 1979 to 2024, generally there was higher median wages in states where there was a lower decline in unionization. The reason for 1979 is that that's generally acknowledged to be the year in which unions were at their peak power of membership. Starting from 1979 is when membership started falling. And then another measure is in 2023, households that were in high union states had about a median or an average salary that was $12,000 higher. Also, in higher union density states, there's a lower share of people without health insurance. Union states also have enacted sick leave education, also more spending on education per pupil. And then lastly, in terms of low union density states, there have been more voter restriction laws that have been passed compared to higher union density states where only 6 laws have been passed so far. So that concludes my report. Happy to take any questions.
Thank you very much. Anyone have any questions for Barry? Item B, staff activities report.
Good morning, Mr.
Cassandra.
Chair, members of the committee. As you can see in the staff activity report, we have completed and submitted our retiree drug subsidy request for CMS. Since posting this in the staff activity report, we have also received the funds for Anthem Blue Cross and Kaiser, which brings our total for this period almost to 9.9 million additional in retiree drug subsidy. Then also we held our Staying Healthy Together program last week. It was a success. We had over 300 retirees, and the majority of those that attended were all new retirees. So it was their first time attending. That's it.
Anyone have any questions? I have a question for you. My question has to do with the letter that our Anthem people received regarding money that they are owed. Those that don't have lifetime medical with their premiums fully covered every month. So where are we on trying to get to the bottom of this and finding out, number one, who is owed money, and number two, how much that might be?
Good question. So what Mr. Robbins is referring to is the medical loss ratio that's applied to the Anthem Blue Cross plan. Anthem last Friday, I believe it was, sent out emails to some of our retirees that were eligible for a portion of that rebate. LACERA, I did not find out until receiving a call from Mr. Robbins, of which he had gotten 3 emails by then. And so that alerted us that something was going on. I did contact Anthem, and they did send out emails to individuals that were eligible. Now, the problem with what we're doing is for the medical loss ratio, Anthem had until September 30th to get these notices out to members. My understanding from Anthem is that they thought the letters were going to go out this week, although the emails went out last week. So that was a little discrepancy there. But just as we've gotten money in 2023 for the same purpose. However, when we get that file or that notice from Anthem, they merely give us a group, such as it might be 1264 LM. Well, that doesn't tell us who those individuals are that are entitled to that rebate. We have 3 months to get that money out to these individuals. We have already reached out prior to even being notified from Anthem. Upon Mr. Robbins' notification, I did ask for them to send over a list of these individuals that are eligible, because there's no way that we would even know based on those group numbers that are assigned by Anthem. So we are working on it. Once we get that listing, I already have staff behind the scenes based off of what information we did get, trying to decipher if we can determine how much each individual may be, but we can't, because it depends on who's eligible whether or not they had 20 to the members. So there's gonna be some research that needs to be done once we get those listing of names. And then we'll certainly get in touch with those individuals to give them their portion of that rebate, as well as the plan sponsor. But we'll keep your committee informed of the status.
Thank you very much.
What is the rebate?
Because they didn't meet, the money, the funds that they used were not all utilized for the purpose of what that money was provided for. It was used for some more like their administrative.
That premium money or?
So the
Copay money or
the
what
Affordable
money?
Care Act established a medical loss ratio, and for large group plans like LACERA, it's an 85-15 split. So
Right.
85 cents of every dollar goes to healthcare, 15% for
Okay,
administration. So based on Anthem's book of business, not specific to LACERA, but for their book of business, their medical loss ratio might have been 84, 83, 80. And so trying to get that back to that 85% level, that's where these rebates come into. And so the tough part, as Cassandra's noting, is that for the vast majority of retirees right now, coverage is, I think it's like a 90% ratio, 90% get everything paid. So it's like trying to pick needle in a haystack, who should get money, how does that work, and trying to kind of work through that dynamic to make sure that members that are eligible actually do receive it. But for the county, if it's their money, it also goes to offset their expenses.
so generally, just at high level, what categories or classifications of people would be eligible for a rebate? You've no,
We don't know
no
who they
general
are.
idea or characteristic, or
No,
I mean, if I were to guess, I'd say
you have no
it's-
idea other than what they tell you?
It's,
Well, what we do know is that if you have 25 years of county service, your monthly premium is fully paid for by the county.
Okay.
If you retire with less than 25 years of county service, you're paying for a portion of your retiree health
Okay.
care. It could be as much as 50%. Service-connected disability retirements that don't meet the threshold of more than 50%, they only get 50% of their retiree health care paid for each month.
So first, it's less than 25 years of
It's-
service, though. it would
It's gonna be
that
those
group,
people that
And then you,
fall into that category where they're paying a portion of their retiree healthcare premium each and every month.
okay.
otherwise it goes to the plan sponsor.
Yes, thank you. Good morning. I had the lovely opportunity of attending the health and welfare benefits event this time around. It was excellent, such a high caliber event. So well done, great speakers. Takes a lot of work to put that big event on. Thank you to everybody that participated. And Mr. Murphy and Mr. Sato were working there. So thank you guys for your help that day.
we're the most popular people because we're passing out the meal tickets.
Yes, absolutely. Thank you for my turkey sandwich. Yes.
I think Mike had more to do with the turkey sandwich. I did the chicken.
Thank you. It was great.
If I could build on that, it's kind of a rare opportunity. It's like, we're there to meet and kind of talk with members, and also when things do come up, we're hoping we can kind of fast track a resolution. Rarity, but actually had someone come up to us kind of mid-morning and say they were having issues with their particular vendor partner in terms of kind of getting things emailed to them. They didn't want physical mail, and they had some other issues. And so we were able to kind of walk them over to the vendor partner they were using, and found out later that morning, it's like everything got resolved like in that moment. So it's like, I certainly hope more of those types of things are occurring at those events, but it was nice to actually be a part of that for once.
Thank you much. Item C, LACERA claims experience. Michael.
Good morning, trustees. Before we start, I just want to let you guys know that we started the 26-27 renewal process. Is my screen sharing? So for this first exhibit, we have the LACERA premium enrollment split by plan. Anthem and Kaiser consist of the majority of the premium, of approximately 80% of premium and 85% of medical enrollment. This exhibit consists of the non-Medicare claims experience. For Anthem, the year-over-year trend increase is 4.6%. For Cigna, it remains flat. And for Kaiser, it's been updated through July of 25 with a year-over-year trend increase of 8.6%, which is consistent with our survey trend of around 9%. This exhibit contains the Anthem claims experience on an aggregate basis and by plan. For plans 1 and 2, the year-over-year trend increase is 4.6%. For prudent buyer, it's a 0.4% decrease. And for plan 3, which is the Medicare supplement plan, it's a 10.3% decrease. The 10.3% decrease mainly due to circulatory cancer and MSK related issues. This exhibit contains the Kaiser utilization report, which was updated through July of 25. Inpatient claims and utilization decreased slightly. Outpatient pharmacy and other service categories increased. And this slide contains the large cost claimants for Anthem, Cigna, and Kaiser. Anthem's year-over-year trend decreased by 5.3%. Cigna was at 4.2%, and Kaiser was at 45.5%. The decrease for Kaiser was related to a reduction in the severity of claims exceeding $600,000. And this slide contains the Anthem lifetime maximum tracker, which will be updated in a future report. And
You want
this,
to talk about some of the things we're making to that?
yeah, so we're waiting for more reports to update it to the $1.5 million lifetime maximum. So we just need comparable data on a month-to-month basis. And then this exhibit contains the pharmacy rebates, which has been updated through June of 25 on a per retired per month basis. The rebates have increased by 9% for the most recent period. And the rebates as a percentage of total pharmacy claims is approximately 30% for the 3 periods listed in the exhibit. And this exhibit contains the dental and vision claims experience updated through August of 25. The dental and the vision claims have decreased year over year. Thank you.
You want to talk about the renewal cycle?
Yes, and so we distributed the renewal request yesterday evening. We expect to receive the renewals November, and we expect to finalize negotiations by December. Thank you.
Thank you very much. Any questions?
Yeah, I have another
Mr. Moore.
question. I was trying to figure out what ambulatory care means this week, and the whole range of possibilities. And I saw something that said when those kind of services are available, you end up with a lower cost than using hospital services. So there's a cost difference in delivery. And I wanted to get a clearer understanding of our providers, basically Anthem, how big a part of their service delivery network is based on, that kind of distributed services where, you go to some X-ray facility that does X-rays and an imaging facility that does imaging. And if you have kidney problems, you go to a kidney center to deal with your problems there. So how much of that service delivery model is incorporated into our plans? And is that an area where going forward, we could push down some of our costs?
I would say that's a great observation. Ambulatory care is going to continue to expand. I actually did a presentation on Monday regarding kind of the Medicare Trust Fund. And I think one of the observations we made is that, Part A is for inpatient services. Part B is for outpatient services, very broadly speaking, Part D for drugs. But if you think about it, in 1965, when Medicare was implemented, everything happened inpatient, absolutely everything. If it didn't, you didn't need the care. And here we are some 60 years later. Much of the work that we have done is done on an outpatient basis because it's more efficient and it's actually better for the patient. So in essence, going, outpatient surgeries, knee replacements are done same day versus being a 2 or 3 day ordeal or episode in a hospital. So it's like that transition is occurring. That's just the natural evolution of kind of care. We're probably going to the next rung, which is having members receiving care at home, but doing it in a manner that is consistent with the overall treatment plan and delivering the highest quality of care. So it's just trying to get someone out of inpatient, which is the most expensive side of care, and trying to push them to the most appropriate, the most comfortable for the members, so they're getting the actual value. So it's occurring, whether it's Kaiser, Anthem, Cigna, UHC, that's just embedded in the system at this point. So it's going to be a natural kind of outgrowth of where we're headed. And, the nice part is we'll see savings on kind of inpatient care, and that'll be replaced by kind of outpatient services. And I think a lot of people try to describe it as like, well, that's good spend. I'm not quite sure what that means, but it's just like we're just transferring it from one area to another. There is some lower spend, but invariably we're going to find something else that takes its place in terms of being the cost challenge. And we'll talk about this in a moment, but prescription
Okay.
drugs. So it's a case of it's like, okay, we're kind of winning on one battle. Now we have a new battle to address. So it's kind of striking that balance. But again, I appreciate you bringing that up because it is an important pathway. And again, it's available across all the plans offered by LACERA.
Yeah, because on my tenure on the board, every time the renewals come up, the contract renewals, is the only question is how much more are we going to pay? And there's not a lot of discussion, at least at our level, on, you know, what are all the things that we're doing to hold costs down and drive them down. And when you find things that work, what can we do to accelerate, support, you know, advocate for those things that work? And that might be, you know, in the state, at the state level or the federal level. So it would be very good for us to understand where we ought to be focused our attention and talking about when we go to the meetings in January.
The good news is your partners, Kaiser, Anthem, et cetera, are very focused on that. Again, as an insured plan, that they are at financial risk once the premiums are established. So if we have services that exceed that budget, they're basically on the hook for that. And so they kind of bear the burden of that. So they're trying to manage that as efficiently as we can. And that kind of push-pull balance is trying to ensure that the members being placed in the appropriate setting. They're not moving someone where they shouldn't be based on the circumstances, et cetera. But again, when we win a battle, we have to fight another one. So prescription drugs is becoming more and more prevalent in terms of its ability to treat a variety of conditions that we couldn't treat before. So again, it's beneficial. So I think we had this discussion last year too, which is like, I'm spending more. Am I getting any value for it? I think we are, but the spend is going in different areas than I think we're historically accustomed to. And so there's value in that process, but the end result is the R&D that goes into that, the kind of the small populations that we're serving with some of these kind of fantastic treatments are very expensive because they're just not spread out over millions and millions of people. It could be 1,000 nationally. So that's the dynamic we're dealing with. So it's like, yeah, we're very challenged in terms of making sure that we're getting value for LACERA and for its members at each renewal cycle.
Okay, well, then going back to my ambulatory care question then, is part of that taking advantage of that, educating our population that using these services that are just as effective push down the overall cost to our whole plan, and eventually it flows forward into lower rates.
I'm trying to manage. We had a discussion yesterday. I'll let you comment on it too. But the idea we were analyzing the emergency room use, which is again another one of the most expensive areas where you can start a medical episode, the emergency room, and trying to figure out, okay, for the level of use that we're seeing, is it appropriate based on the circumstances of each individual case, and how does that benchmark? Surprisingly, LACERA's ER use relative to Anthem, who we were talking to yesterday, relative to their book of business, LACERA was actually at a better kind of threshold number than Anthem's book of business, which means, again, your members are using ER appropriately. And I think that's a real challenge because, again, we don't want to create a barrier to members who might not get to the hospital in time and could have an episode that could become very complicated. So it's like, it's kind of an interesting balance, but I think we're going to try to alert members to urgent care centers, which are less
The more
expensive.
information you have, the better decision making you can make. Okay.
Mr. Kehoe.
Yes, so one of the top complaints I hear from retirees is regarding our dental benefits. Do we have any insight on what's driving the decreased use for dental and vision year-over-year decrease?
I would say the challenge for dental, particularly for retiree population, is that when you do have an episode, it's going to be expensive. You know, kind of early over your lifetime, it's, you know, routine services, maybe a filling, but once you get to this level, the expense associated with it becomes a little bit more of an obstacle, because crowns or replacements, et cetera, implants, you could be looking at thousands of dollars. And so the members kind of having to probably budget for that to kind of make up that difference. So it doesn't eliminate the care, but it might delay it, which actually could increase the overall cost because we're not addressing it as soon as we could. So I think it's just a matter of education. I think trying to help members find maintaining relationships with dentists and then trying to receive routine care to kind of manage that process. And again, vision care is just, it's a once a year episode. It's just ideally, as long as members do that, that would be great.
So on the dental side, it's more driven by episodes versus routine care. So that's why it could potentially be decreased, less episodes for the month or the year.
Particularly for the retiree group, because I think it's a matter of, it's like, do I want to spend my money on preventive, or am I going to kind of reserve the benefit available to me for that major episode that I probably know is coming, or kind of anticipate that it could happen to me. So that's probably the only detriment on the dental side.
Okay. Thank you.
We have worked with Cigna in the past, once we saw that the usage was not up to par, and reaching out to retirees. At that time, the usage went up for a bit, but then it went back down. So I don't know if it's, they need reminders, or as Mr. Murphy said, they look at what the cost is going to be and whether or not they can afford it, and putting it off until they save to have that service.
Got it. Thank you.
Thank you very much. Item D, federal legislation.
Yes,
That
sir.
discussion we had before the board meeting, let's just hold that until a future meeting, and we'll make it an agendized item.
Love to. All right, from a legislative compliance standpoint, we included a highlight on some of the HIPAA language changes related to privacy, and it has to do with reproductive rights as well as mental health substance abuse. We're working with staff and your insurance carriers to make sure that the language edits that need to be made, I think by February, are incorporated, but the responsibility is primarily on your carriers, not LACERA. So we'll continue to work with them through that process, but it's there for your reference. Nothing else to add.
Do you have any questions?
Highlight answer. Highlight answer.
Arlene?
Thank you. So what does that mean, removing the reproductive healthcare updates out of the HIPAA privacy statement?
There was some, the Biden administration issued some additional protections for reproductive
remember.
rights. And just to be blunt, it was related to abortion care. There was a district court in Texas that nullified that finding. And so they kind of removed those rights. So in essence, the HIPAA statements that would have extended PHI protections to those individuals for those specific reproductive right treatments don't exist any longer. And I suspect it's primarily related to states like Texas and others in kind of middle of the country.
Yeah, no, I kind of understand that part. I guess I don't understand, like, what does that mean? Is that open for, it's not PHI, so it can be transmitted without any?
My sense is the intent was, because I think there's some rules or processes that you can quote unquote identify someone that may have had an abortion and kind of bring them under prosecution. So it's like by removing the
Got it.
PHI there,
Got it.
gives them access to the information. It doesn't remove it kind of broadly across the
Got it.
spectrum. But so I appreciate the clarification.
Okay, thank you.
Sure.
Thank you very much. Any other questions for Steve? Item 7, items for staff review. Nothing. Items for future agendas.
You have one item. You'll
Yeah,
start
just
with
what we discussed earlier.
Okay.
It'll be a surprise. And we'll say good of the order for the regular board meeting, and we're going to start that meeting in 5 minutes. This committee is adjourned.